session is titled Digital in Mental Health, Hit or Miss. We have Soumya Chowdhury from NIMHANS who will be making a presentation first, and then she will be in conversation with Leena Raghunath discussing the presentation. The presentation covers her findings on the efficacy of tech-enabled approaches when it comes to preventive, promotive, and curative aspects of mental health. And she will cover self-help wellness apps, digital mental health, telemental health, and of course, AI in the midst of all of this. This, like I said, will be followed by a conversation with Soumya and Leena.
Good afternoon, everybody. My name is Soumya. I am a PhD student at NIMHANS, and I'm a research fellow at Division of Digital Psychiatry at Harvard Medical School. My interest from the past 6 years has been in the field of digital mental health. And why is that so? So why do we need digital mental health? Any quick thoughts? Mental health is, we know that it is a problem, but now we have hard facts, evidence, statistics, information about why is it a problem. And what you see on the screen is just a survey that was done this August 2024. 25,000 people under the age of 79 across the globe were asked, what do you think is your top health concern? And they all said mental health. Mental health is my top concern. It is closely followed by cancer, stress, obesity, etc. Now imagine this level of rise in mental health demand in a thinly stretched, low-resource country like India, where one of the studies that came out of NIMHANS was the number of years it will take for India to build the team that it needs to meet the demand today is going to be 72 years. 49 to 72 years to build the clinical team that we need to meet the demand that is there today. And this is where digital mental health comes in. Digital tools can be accessible to anyone. It can reach anywhere. It can go into any type of low resource setting. And my definition of low resource is not just rural settings. My definition of low resource is anybody or any household or any area that does not have access to mental health care at the time when they need it. How many of you can relate to the common misconceptions that are there on the screen? 6 years ago, when I started my journey in this field of digital mental health, I was like, is it just an app? Is it just a device? Because one of my first experiences was building a watch for kids with Tourette syndrome. And I was like, is this digital mental health? But how many of you have thought that it's only for people who are tech savvy? Anybody here who thinks, great. Research would show that older people adhere better to mental health apps than younger people. It is not true that younger people do better with mental health apps. It's exactly the opposite as to what we think. Is it a therapy? Is it a chatbot? What is it? Like, who knows? What it exactly is a lot of things, but the definition that we are trying to make is it is the use of technology, any form of technology, for the purpose of prevention, assessment, treatment, and recovery of mental health care. Mental health is a very comprehensive concept. We cannot target one vertical and say we're going to ignore the rest. If an approach is being adapted into this field, we have to adapt it from all angles. Now, because this field is like 10 years old, 10 years, 15 years at max, and the maximum amount of research that has been done has been in the last 5 years. It is rapidly evolving, and what happens when something rapidly evolves is it comes up with too many concepts, and the lines between those concepts becomes very blurry. And that is what has been happening with this field. Currently, we are still defining, the experts from this field are still defining what is the inclusion criteria for something to be called digital mental health, and at the same time, what is the exclusion criteria for something that is not digital mental health. So for the sake of this talk, I have tried to bucket key concepts together for us to understand what are some of the key concepts. Now, it is a spectrum. The first approach is the concept approach. Now, this is in order of the most recent to the oldest foundational aspects of digital mental health. One of the first things that India nailed down was telemedicine. We could call up a helpline, we could call up our doctor and talk to them on the phone. Then we came up with synchronous, secure video conferencing lines with our doctors. NIMHANS came up with Telemanas, you can now call us on helplines, and that is a solid foundation that we know. Then we came to digital therapeutics, which is now a mix of new and old. How many of you remember self-help apps back in like 2016, 2017, when we started to get smartphones? We had self-care apps, the apps you could download and be like, okay, I can get meditation now, I can get mindfulness. YouTube was giving meditation out like anything. And now, from those self-care apps, we have come to apps that provide interventions being regulated as Class 1 medical devices by the FDA, which we will talk about in the future. The most recent digital mental health approach is digital phenotyping. Phenotyping is basically making characteristics of somebody, and digital phenotyping is, it's like a blood report of your smartphone. Blood report will tell you what's going on inside you, and digital phenotyping tells you what's going on with your digital behavior based off of your smartphone. Another approach is the technological approach in this spectrum. So from the left to the right, we go from easy to use, user-friendly technological approaches that we all know to more sophisticated artificial intelligence approaches that are not so common to use but are being researched into more defense sectors of various countries. So for example, digital mental health apps would be any apps that you use. To virtual reality is being used for PTSD, where you wear a virtual headset. And veterans, this I was doing back when I was at Harvard, we would make veterans wear headset, and their combat situation would be simulated while a psychologist would be present to see how much trauma they can handle, and then probably make a treatment plan based off of the stressors that they see that they can expose them to. Natural language processing, has anybody ever written into a chatbot that, hey Siri, I'm not feeling great today? Or, hey, like, can you tell me what to do to make myself feel better? And the chatbot replies, if you're not feeling well, follow the following steps, so and so. Those are natural language processing models, and they are becoming increasingly common. If you have ever spoken to Alexa and told her, hey Alexa, can you play me a song to make my mood feel better? Those are smart speakers. Those are all the NLP approaches that we take. Now we go from the easy-to-use apps to the data science and machine learning aspects of digital mental health, where data science is all the big data stuff. Like, big data would mean like complex time series data that are collected over a period of time. They are very densely enriched with the information that you collect from your smartphones or any other devices. They will help you see patterns, whereas machine learning will help you predict responses. And then we have robotics and sensings, which is something that is outside of my area of interest as well, but they exist. Then there's the devices. We have the mobile devices, we all know wearables and smartphones. We have the hybrid devices, which are tablets, and hybrid because you can have them at home, you can have them at your office, you can have them with you on you. It's the desktops, laptops, tablets, etc. And then we have the home appliances, which are the VRs, the video games, smart homes, like I was talking about, smart speakers, etc. And this is my favorite slide. It's the care models. So we know mental health there's no one size that fits all. Similarly, with the approaches that we take to integrate digital mental health cannot be one size that fits all. We need to have different care models that are suited to individual needs. So there's this self-care model where you have the self-help apps. So this is really good for people who are just exploring and they want maintenance therapy just to sort of feel good about themselves and they want to check in. This is completely self-guided, no clinician, no person to sort of nudge them. They have to have their own motivation, which is the challenge, and that is why, because motivation fades away, engagement fades away, outcome is not very effective. So that is one of the problems with self-care apps, but that exists. Then there's the guided apps where you have a peer support. So you go, you log into your app and I want to schedule a session with my therapist. The therapist will reply back to you, let's do it at this time. You leave her some questions and you have peer support guidance for that session. And then there's the hybrid, which is, I'm going to talk more about it, but this is going to be probably the only way digital mental health is going to work for the next 10 years, is if we have a mix of the best of both worlds and have a hybrid model. Now, the way a hybrid model works is it gives you your own freedom to have self-care apps that you can do, but you also have nudges from your clinician in between, like, hey, how are you doing? I recommended you on this app. Has it been helping you? Let's discuss the insights when you come back for your 30-day follow-up. This is really good because somebody who has mental health issues, they will always never need the same level of care. They will have fluctuating needs and they'll need fluctuating levels of care. And that's what happens with hybrid models. You can increase or decrease the support as per the individual's needs. This is my area of interest, and this is what I've been doing my PhD in, and I've been working from the last 3 years into this field. It's called digital phenotyping. It is collecting active and passive data from your smartphone to make real-time insights of your behavioral patterns. So now what is active data, what is passive data? We all have a smartphone, we download an app. The app asks you, let's take a mood survey. You answer some questions on the survey. I feel little interest or pleasure today, not at all. I feel a lot of worrying today, maybe sometimes. That's active data, something that you're actively inputting into the app. And then there's the passive data, which is the sensor data. How many times have you locked or unlocked your phone? What types of apps have you visited? How many times have you gone out of your home today? What is the GPS location, etc. For this, you don't have to do anything. You just have to use your phone as you normally would, and the app would collect all of this. Combining these two, it gives us a very objective, real-world look into you as a person. What does your digital behavior tell us? And what judgment can a clinician make out of this data to add it as an aspect of clinical assessments and make informed treatment plans? The data looks something like this. This is from one of our dashboards of a patient. It's too complicated to look at, but very easy if I explain it to you. So we have the graphs, which is the sleep graphs. How much has the person been sleeping? Is there fluctuations in the sleep? The one on the left is the accelerometer heat map. Has he moving the phone more? Has he been fidgeting with the phone a lot more? How many locations has he visited? How many steps has he walked? Has he done has he logged his medications? Has he been missing his medications? So this is a mix of the active and the passive data from a patient who has been using our app, and we would go with this to the clinician and being like, we have noticed that the person is reporting high anxiety, has not really stepped out of the house, his physical activity has reduced, he's not sleeping so well, so maybe we should call him in for a checkup. Why is digital phenotyping useful? It monitors behavioral changes in real time. I visit my psychiatrist on day 0, and I visit him on day 30. There is no monitoring that the psychiatrist can do between the 30-day period when I'm not there. And the app does that for him. It can monitor how is the patient responding to any dose of medications. Is the CBT working? Is it not working? Is it actually making the person feel better? And this is one of the main goals of this field, is to give you real-time insights into the patient. It allows for the feasibility of collection in high ecological validity. High ecological validity is a fancy term for real-world use. Like, if I am answering something today, it is true to my current self, and I'm not answering this in a clinic or a laboratory where I have traveled like 40 minutes in Bangalore traffic and I'm already frustrated and I don't want to like say what I'm feeling because I'm actually frustrated. So high ecological validity would mean that answering your symptoms based on in your naturalistic environment, which are true to yourself. Very scalable. Everybody either has a smartphone or is going to have a smartphone. Smartphones are the #1 way to reach people anywhere in any corner at the moment. And if there is a technology that we can leverage safely and ethically to help the patient, why not? Predicting relapse in psychiatric conditions such as schizophrenia. This is one of my research topics. I'll talk more about it, but let's say a patient with schizophrenia is about to relapse, and we can see the data that he's about to relapse. We will call him in for a checkup because it'll help us mitigate the outcome of the relapse. Informing personalized treatment adjustment based on behavioral data. There is something just called just-in-time interventions, that the moment we see that the person is about to relapse, and he can't come in because he's rural or he just doesn't want to come in, we can trigger a just-in-time intervention through the app and be like, can you do this exercise? Can you take this CBT exercise? Can you take this mindfulness exercise? And maybe that helps him feel a little better at that moment. Lessons from our implementation. So I've been working with Dr. John Torres. He's one of the experts in this field at Harvard Medical School, with Dr. Urvaksh Mehta here in NIMHANS in a study called SHARP. SHARP is smartphone health assessment and relapse prevention, where we are trying to see, can we predict relapse in schizophrenia? Overwhelming majority of schizophrenia patients have their relapse in the first 5 years. And the more the amount of relapses, the poorer outcomes for their medications. If we can predict it, we can improve those outcomes. And the one thing, so this is how the MindLab app looks like. It's a study funded by Wellcome Trust in the UK. We have 4 components in the MindLab app. It's an open source app. We have the learn, which is a psychoeducation component, the assess, where they take in or give us the active data, the manage is the meditation and soft interventions that we try to provide, prevent is where the patient can see their progress. But through this app, we collect sensor data, which is de-identified. And anybody interested in the field of digital mental health should know the key term, which is data privacy and de-identification, which is, the data should never say Soumya went to the airport and then to the cafe. It should say user ID 123XYZ was in this area, particularly at Brox this much time, and then went on to another area. And we established that de-identified and aggregating protocol with this study. And we collected a lot of passive data to see something very interesting, which was this. We could predict relapse in schizophrenia. The black vertical lines are the 2 time points that the patient relapsed. This graph is of one patient, and the black vertical lines are the 2 time points when he had a relapse episode. The horizontal black dotted line is the significance level. So in research, if something is above that black dotted line, that means it's significant. If it's below that black dotted line, it means it's not. You can see that there are anomalies. Anomalies is basically unusual patterns that we see in the data right before, like 10 days or 12 days before the patient is about to relapse. And we couldn't do anything at that point because this is a retrospective analysis, but this was a strong evidence that predicting relapse in schizophrenia is possible. We come to digital therapeutics. Digital therapeutics is, again, as I said, any apps that try to provide interventions to an individual based on whatever they want an intervention for. Initially, they were not regulated. Now, with the advent of more and more technological approaches in this field, FDA has tried to label something as class 1 medical devices, where A, because insurance can be reimbursed, and second, they are now having more and more clinical validation. They are going through RCTs to prove that they can actually improve treatment outcomes. And that is what there is a need to define this field, and it has come up with the name called digital therapeutics. In 2017, there were more than 10,000 apps. That time, there was no COVID. Now we are in 2024. I don't even have a number for how many apps that are there right now. It's a very interesting question if somebody ever wants to answer. There are a lot of apps, and we don't know what is a good app. Like, there's no best medication, there's no best therapy, there's no best app, and we don't know what that is. But a lot of the key pharma companies are trying to come into this field and try creating digital therapeutics, get them regulated for different disorders like schizophrenia, opioid use, insomnia, major depressive disorder, etc., and trying to get them regulated so that they can actually prescribe such apps to the patients. What does research tell us? It is feasible. Yes, we know that it is feasible. Everybody has done some small-scale pilots with 25 to 50 patients, and they've shown a significant amount of effect in patients that, okay, it is feasible to conduct digital mental health interventions or use digital mental health to predict treatment outcomes. So we know that, as a matter of fact, for sure. It is accessible, as I said. Smartphones are there. We know that it is accessible. It is acceptable by the patient. This is something that we have also done. We have done focus group discussions, a lot of qualitative findings, a lot of quantitative findings with caregivers, with clinicians, with patients themselves. And they know that, okay, we want to use this, but let's see how much can we use this. Something we don't know is that it is harder for clinicians to implement. Now, a clinician is a very busy person. They already have to deal with the existing EHR systems or the health record systems that they have to. You have a high patient load. Where is the time to have an additional layer of digital mental health and look at the data? You know, you can't even handle the data that is currently there. How will I add another layer to my clinical assessments? Some clinicians are interested, some are not. So that is a so-so field right now. We don't know what is going to be the conclusion about it. But is it effective? That is the main question. Are such apps effective? How many of you have a mental health app on your phone at the moment? Exactly. So we know that people use it because they feel, is it effective? But is it effective? Most of the efficacy levels that we are seeing from systematic reviews coming in or meta-analysis coming in, they pool in effect sizes of, say, 200 apps or 150 apps, and all of them say minimal effect size. Minimal effect size means minimal impact, minimal efficacy. And that has been one of the latest ones says moderate efficacy. So there is not a high efficacy, high impact self-help apps that have come out. Digital literacy is a challenge. Now, imagine, it's an assumption, right? We make that everybody who has a smartphone knows how to use a smartphone. That's not true. These apps, even though they are very user-friendly, navigating an app when you're anxious, when you're depressed, when you feel stressed, is going to be a hard task. And when you don't have enough digital literacy tools available in your cognition, it can be a hard area to navigate. We need to work towards improving digital literacy across all sectors, not just rural, urban, rural, both, and have apps more in more local languages. English, Hindi, yes, but more local languages so that everybody can make use of such things. Not all apps are scientific. Any app that you see being advertised, if you ever go onto their website or there'll always be a publications or press area on the website. You see how many scientific studies have they reported. One of the studies done in 2019, 59 apps claimed that, okay, we are effective at diagnosing mental health conditions. They claimed it. But when you go onto their website, when you look them up, only one had one study published with 20 people saying, okay, this is effective. So not all apps that you see out there are scientifically based. Not regulated, as we have discussed. Data privacy is a challenge. People are obviously sensitive about their data, as they should. Who will handle it? How will it be stored? Can I withdraw my data? For research, we can inform all of this through informed consent forms, and they have the privilege to discuss it with us, and we can talk them through the data privacy areas, but not general public. And this is a challenge, because what type of data is being collected? How is it stored? It's a black box for such mental health apps. Adoption of such technologies is at nascent stages, which is true, because when you think about such things, it's not just the patients, but the clinicians as well. They are at the core of patient implementation, so they should be okay to implement it. They should see value in it first before they want to implement it. And that is currently, again, another gray area. Research evidence is very preliminary. A lot of pilot studies have been done. Pilot studies, like people have said 25 people, no control group, 25 people use this app, they got better. How do we know that the other group did not get better? So we need more R-series. And for a drug trial, you can have an active group, which takes the active drug, and then there's the control group, which takes the placebo pill. But how do you do R-series with mental health apps? What is a placebo app? Is it a blank app? Is it no app? Is it the app but with limited features? That is unclear. How to conduct good randomized control trials in this field so that we can really see the efficacy of such apps is a question. And the Achilles heel is app engagement. People don't engage with mental health apps. You see an advertisement, you get curious, you download it, your clinician recommends it to you, you download it. But as the motivation fades, so does the engagement. This is a very interesting study. I should have tagged it, but if anybody wants, I can share it with them. This is irrespective of what app and how user-friendly and what type of features that they had or they did not. Most of the apps, after the 12-day period, there is a very, very small fraction of them who are really interested in actually trying to use it. And by the time, the only yellow line that you see in the right-hand side is the peer support one, which is basically somebody who's talking to you on the phone and you actually have a human connection on the app, and that is the only app that survives engagement. And the rest of them, after 10 to 12 days, they sort of, either your operating system will kill it because you're not using it, or you will yourself delete it. What is the way forward? Now, initially when I started this journey of digital mental health 6 years ago, I was really enthusiastic, and I was telling my mentor, Dr. Vaksh Mehta, that this is the future, and he was like, this is not the future. And over the time, 6 years, yesterday when I was having a discussion with him, he's like, I'm confident that you can give this talk because now you know what the problem is. And I agree. But there is a way forward. And the way forward, there are many. But the two broad concepts that I'm trying to get into my research, and I'm trying to talk to other people who are interested in this field, is we need something called a digital navigator. When you go to your x-rays or ultrasounds, there's always a technician who's there. There's somebody who's doing it and somebody who's interpreting the report, and then obviously there's the doctor. And the field of radiology adapted to it very well. And that is what this field has to do. We need someone called a digital navigator who will help the clinician recommend apps which are scientific, who will help the patient onboard the app, help them with troubleshooting, because what do you do when an app doesn't work? You know, what do you do if you have suicidal ideations? You go to the app and the app doesn't work. What do you do then? You need somebody to call and be like, okay, I need the app, or I need to talk to my clinician. And you need somebody to sort of demystify the data and convey it to the clinician that, hey, this patient is having such and such things, you might want to factor this in into your next treatment. That is the role of a digital navigator, and that navigator fits perfectly into the hybrid model of care. This is the model that Harvard follows. They have something called a digital clinic, but this model can't work in NIMHANS because we don't really have like PCP referrals and stuff like that. But the way this can work here is, if I go to my psychiatrist on day 0 and they're like, okay, you are interested in continuous monitoring of your behavior, let me suggest this app to you. Somebody will onboard you on the app. I get onboarded onto the app by a digital navigator, and they tell me, these are the activities that you have to do. Do it at your own time. You'll get notifications, but I'm not gonna like bug you to do those activities, but I'll check in with you every 2 weeks just to see if you need any support. And on day 30, you can come for a follow-up. So the digital navigator checks in with me at 2nd week or 3rd week, and day 30 I come in for a follow-up, and my data is already with the clinician with the insights that I've not been sleeping well, I've not been going out, I've not been taking my medication, and then the clinician will be like, hey, we've noticed this, do you want to talk about it? So that is the hybrid model of care, where it gives you the flexibility to use the app activities whenever you want to, and there is somebody to help you, nudge you with the engagement, and the data is actually being conveyed to the clinician so that they can really use it, and it is not just for research purposes, but actually a model of implementation. Stakeholder-centered design. I cannot stress on this more than what I want to do. Is you cannot make apps without involving patients in them. Most of the funders today, Wellcome Trust, NIH, any big funders won't fund your grants if you don't have lived experience experts, patient advocacy groups, while writing the grant, and they also get them to review the grant. And they are on the panel. When you're interviewing for such grants, they are on the panel. Somebody will ask you, okay, this is for me, somebody, my community, how am I going to be, these are my questions, these are my challenges. So now what we do is we do FGDs, focus group discussions with patients. We give them the app, we show them the app, we do it with them, we do it with the clinicians. They can give us as much information as they want on how we can make it better. We make it better, we go back to them, we are like, we want to do something called co-designing, which is we want to design this app with you and not just a group of developers sitting in a lab and making something that doesn't work. Stakeholder-centered design is the one way to make your app really for the people that you're trying to make it for. Now, as I said, there were 10,000 apps back in 2017. How many are there now? Who knows? But American Psychiatric Association decided that we have to do something because a lot of people are getting, the wrong apps are being suggested to a vulnerable population. So they came up with something called an app evaluation framework, which is you can assess apps now based on these 5 points, which is context, assessing for harm, potential for benefit, usability, and my favorite is interoperability. That means how will you share this data with other healthcare systems, and how can it help integrate other healthcare systems information into the patient's treatment based on this data from the app. And Dr. John Torres's team at Harvard did something more with it. They created a free website called mindapps.org. It should have been there, but it's mindapps.org, where you can go. It's a free database of all the apps, where there are research assistants who rate apps that are there on the App Store. They type mental health apps, they see popular apps, they get suggestions to rate apps, and the ratings look something like this, where they give qualitative review ratings, where what is the cost of it? Is it scientifically validated? Is there data privacy? Has the information about the data privacy been shared? So you can really just go onto the website and type CBT depression free, and it will give you all the apps that are CBT depression free, and you can really look up the ratings of such things. This is one step forward into making an informed decision about such apps, because how do we know what really works? FDA has been very unhelpful in this field, but now they are waking up and they're like, okay, we need to do something. So they started with the most basic thing is by defining this field. They have come up with a glossary that is called FDA Digital Health and Artificial Intelligence Glossary, where they are trying to give definitions of what are some of the things in this field, what are some of the keywords, how can you really define it, which is a step into standardization, but a step too late. There are already these definitions that exist, but a very interesting glossary to look at. India's potential. This is a paper that I wrote this year, which is what is the scope, challenges, and future of digital psychiatry in India. There are a lot more challenges, but there is also a very, very big scope. We have nailed down telemedicine, as I told you. There is a lot of data on the way that synchronous communications with your clinician can work. But there is also a big promise of smartphones that is coming up. Urbans are not adapting smartphones and internet as fast as the rural population is. But again, that doesn't mean that they know how to use it or they're going to benefit for it. I just know that there is an adoption and a penetration of India about smartphones and internet. We can leverage this for the two main concepts, that is digital therapeutics and digital phenotypings, like I discussed, to help bridge that gap a little bit. It is a very interesting thing, that graph, the one in bottom right. I looked up Google Trends when I was writing this paper. I wanted to see what are people in India really interested about digital mental health apps. And you see the flat line from 2019 to 2020, there was no interest in mental health apps. Nobody really looked up the word mental health app. They must have looked other words, but the word mental health app was not searched. But look at the graph from 2020. The interest from post-COVID to 2024, which is like this year, it has only been rising. And this is just a very layman report coming from Google Trends. So we know that there is an interest, we know that there is potential, we know it's feasible. We now have to figure out models of how we can really help the ones who need it the most. What are some of the current trends is definitely the Ayushman Bharat, the National Digital Health Mission. Nothing very significant has come out of it yet, but they're trying. They're trying to make policies that will help create infrastructure for digital health tool implementations, and that is always the first thing that we should do. We should have the infrastructure to conduct these tools, because if you dive into a swimming pool without knowing how to swim, then you're probably going to drown. Then there's the mental health startup boost. There are a lot of startups that are coming up after US and Germany. India is one of the leading countries that produce the highest amount of mental health apps. Nobody knows what goes on in China, so we know US, Germany, and India. We are setting up regulatory compliances. The first law that is coming up that is comparable to HIPAA and GDPR is the Digital Personal Data Protection Bill. Government has released it. They have released the outline of it. Now they are trying to figure out what are going to be the tenets of this, but it is a step into the right direction. Not just Indian apps. Any app that wants Indian data or they want to have an Indian population base will need to have DPDP, will need to be DPDP compliant. Adding to the research evidence. So institutions like NIMHANS, AIIMS Delhi, Bhopal, IIIT Bangalore are working in synchrony to come up with more evidence for this field. In summary, digital mental health has a broad scope in India, a very broad scope, not just in India, but across the globe. But here we have preliminary research evidence. Around the globe, they have a stronger research evidence, but there is the scope. It can potentially help with reducing treatment gap. I will not say that it can for sure help, because we don't know whether it can for sure help. But there is a potential for it to reduce the treatment gap. There are many apps to choose from. We have to make informed decision making when choosing such apps. And digital literacy of patients should be the first step. When you want to recommend an app, first figure out whether they are interested, then figure out whether they know how to use it. And if they're interested but don't know how to use it, try to do that first step of providing them with digital literacy, and then probably go on with the second one. Thank you.
When I first heard about this topic, I had many questions about what digital mental health is, because as we all understand, digital is one of the world that harms our mental health the most. After it has come into our life, we have been affected by the fallouts a lot. But then, as you said this is the future, and you said now you are rethinking after spending 6 years in research. But from what you have explained, it's very clear this is the future, right? There is no way that we can not go this way and reach the kind of, because the gap, the bridging the gap is that huge. As you said, it is another 72 years before we would be able to build the kind of resources. But also from what I've understood through your presentation is that you're not advocating self-help apps, right? Because they don't serve the purpose unless your therapist, your clinician will recommend a certain kind of app for you to monitor your whatever your illnesses. You self-predicting and downloading an app and working on it might not work in your favor. Is that what?
So I'm not saying the self-help apps will not work for anybody. I'm saying the efficacy levels are very low, and they're low because there's poor engagement. So if you can make yourself to use a self-care app for like long periods, and if it helps you, then great. But the research shows us that people don't engage, and it really, because you don't engage, you don't get good outcomes, and that is why we have poor efficacy levels of such apps.
Right. That engagement graph that you showed, that after 12 days the engagement just drops. So I'm questioning that data because I'm just wondering why people dropped after 12 days of engagement. Is it because you don't know, you found this on internet, there were some ratings on it and you went after it. But whereas unless you can take the results from that app and tell it to your doctor that, hey, this is what this app is telling me, and that doctor is able to verify that data and put it into the therapy that he's going to offer, what is this self-help app gonna do for you? So my question is, when a center or your therapy center or your doctor recommends such an app to you, does the same thing happen? Do the interest even then fall after 12 days, or is it better? There any studies that look at it in that way?
I haven't really read any research studies that are targeting therapeutic centers or doctor recommended app per se, but I know that if there is no human nudges with people with mental health care needs, the app engagement is probably going to be low. And they will not interact with this app. This is a universal concept. This is not that it happens in India or it doesn't happen in the US or it happens there. But you need a certain level of adherence with such apps, and that comes from a human nudging you. Notifications you can easily just slide off, but if there is a nudge that you've agreed to, like agreed to somebody to call you once in 2 weeks for you to follow up with that, then that is probably a better model than, even if a doctor recommends it to me, I might just not use it. We do that here. Like, we tried it with our research study. We gave them the app, and if we didn't call them, they would not respond, and they would not engage with the app. And when we called them, they would engage with the app. So it's just that the difference.
Right. With the kind of doctor-patient ratio that we have, I think it is very important, the kind of system that you have suggested, that there should be someone who takes them to the technology and continuously inputs the data and explains the data and take it back to the doctor too, so that the doctor meets them at day 0 and then goes back to their medical records on day 30. But this app's data, as you say, if you have to predict and you have to intervene at a significant point, needs to go back to them, to the doctor. And right now the medicine system, does anywhere in the world have that kind of adaptability to look at that kind of a data?
Some clinics, which are digital clinics, that they have this as their protocol, do it. There's one in Germany, there's one in the US, there are a couple more around, I think, Brazil. But I have not come across such models, at least in India. This is something that I'm trying to add to my research, that there is a digital navigator who's going to interpret the big data that we get and get it to the clinician to sort of incorporate into the treatment program. But the adaptability is there. One question that actually comes with digital navigators is, who's going to fund this role? Because it is such a, it's a gray area, right? Is it a technician? Is it a nurse? Is it a psychologist? Is it a doctor? Who is a digital navigator? And because that doesn't have enough scientific qualifications, who's going to fund it? What is going to be the salary of this person? What are going to be the hours? So this role itself is such a gray role that adaptability is not really defined, but the potential and feasibility exists. But if you have to have a hybrid model of approach, you need to have this. And that's the interesting part, that a nurse can become a digital navigator. Anybody can become a digital navigator because it is just the role of a troubleshooting, and you need soft psychological skills to just calm the patient down if they need it before you can accelerate it to the clinician.
But the treatment architecture, as we see in most places, will have to change and adapt in a big way to take in this kind of technology and its feedback. And I don't think that itself would take maybe a 25 years of treatment architecture changing. Or is it? Do you think that as more apps come in, the medicine system would adapt to it?
I think we will figure it out together. We will really know that what kind of investment, logistical infrastructure, HR, what kind of investment is needed for us to really be working with the clinical tools. If that was nailed down, we would have probably adapted to it. But now we don't know, right? Like, we don't know who is the right candidate for such apps. Is it everybody? Is it nobody? Is it severe mental illness? Is it common mental illness? Those are the things that we are still trying to figure out. But to answer your question, that we're all going to figure it out together. Like, as research progress, we will know what are they going to be, how much time will it take, how much have we progressed, what more can we do to adapt better, what are the challenges. The challenges that I presented today are like superficial challenges. There are even deeper level of challenges that we face on a day-to-day basis. Internet not working, internet charges, it drains out the battery. Such apps drain out the batteries of the phones, then people delete it on their own. So what is the level of technology, what is the level of patient interest, infrastructure, clinician interest that we'll need is something that only research can tell us in the future.
Another thing from your presentation that I found very interesting is that I had a very young colleague right out of college, one of the happiest, most smartest guy, and one day he wanted to leave office early and he said, like, I have to go for my session. And I said, why would you need? So he was like, so that I don't grow up like you, Leena, and fuck up a lot of other lives before I realize I need therapy. I was like, wow. I admire that. But your presentation says that younger people, doesn't use these kind of apps more, and it is elderly patients who stick on with these apps. So I found it very, because to tell my parents that there's something wrong with them and they should go to therapy is like an impossible task. But,
yeah.
But you say they rely more on apps.
So I'm not saying they rely more. I'm saying they don't find it challenging. Like it's not like people who are tech savvy can only use these apps. Even older people can use these apps. They don't really rely on it. They are the biggest skeptics of this field. And because they are the skeptics, they are very motivated to see, is it working? Is it working? And if it works, then that's really nice, right? So the older people are more inclined to stay longer with these apps, to use these apps with a better motivation than young people, because they will shift from one app to another. But the point that I was trying to make is that you don't have to be tech savvy. Like, you don't need to be born in this generation to be using mental health apps.
So you also feel that there is no rural-urban divide when you suggest an app, like, does that divide reflect in the usage of the app?
No, not really rural-urban. Like, there is a divide in terms of digital literacy. Most of our patients that we have in our SHARP study, from SHARP 1 and now, I don't think I have an urban patient. I have 2 urban patients out of 25. 23 patients are all coming from rural areas or coming from other diverse socioeconomic statuses, and they are all very happy to use the app. The one thing that I had to do is the learning curve with the app, like how to use the app, how often to use the app. So the rural-urban divide is not really there, other than the fact that the digital literacy apart, but there's a divide in high resource and low resource settings when you use these types of apps.
I think one of the reasons that youth also don't engage with these apps is data privacy and those worries, right? That you carry this device around with you. You're constantly telling the device your most personal experiences of, and giving them a sense of how you're living your life. So putting them in charge of what your brain and emotions are going through. And how far has apps come, in addressing those kind of concerns that the youth have?
It's actively addressing. The apps now have to they are supposed to be declaring the data that they collect, but it's fine print. That is the problem. That it's all in the terms and conditions that you agree to. Where is it going? How many cookies is it being shared? How much is your data being sold to this thing? Is this data de-identified or not? Like the apps don't tell you that, because usually for mental health apps you would log in with either your email address or you log in with a username or password. They will ask you for your birth date, etc., etc. And is this information de-identified? Is the app HIPAA compliant, GDPR? I feel apps should say it on their first screen, like we are HIPAA compliant, we don't collect data, data is de-identified. And I have not seen modern mental health apps do that. Only research apps do that. So not just youth, I feel anybody is sensitive about their personal information. What is it collecting? Where is it going? Because then you suddenly start getting recommendations based on, mood lighting. If I search, okay, low mood, I'll start getting mood lighting recommendations. And that is a problem. So those are the things that, it's not just a youth thing, it's an everybody thing. And apps are working towards it, but since there's no regulation and because there's no oversight, the apps can vary. Who's looking? Who's regulating them? Who's penalizing them? Nobody's doing that. So it's an open, wild market of data privacy that they can violate. So those are the things that you really have to be careful about. And then these mindapps.org come into play, because you can go and look up, is this app doing the stuff that it is supposed to do? And anybody is welcome to suggest. Like if you feel... because I work closely with that team, if you feel there's an app and that's not on mindapps.org, but you would like it to be rated or reviewed, you can just drop them an email on their website and they'll review it for you, and it'll be there on the website in probably 48 hours as to does it follow data privacy or not.
How many doctors are in India equipped to handle these kind of platforms and information that comes from these kind of platforms to help the people who are in front of them, who are seeking the advice?
I have no number of that percentage. It is an unknown area. I mean, probably a good area to research. I will write this down. We don't know how many doctors are equipped right now, but there are clinicians who are interested in NIMHANS. We work with them. We try to, but this is one of their biggest questions, right? Like, how do I implement it? So across India, I won't have that number, but there is a growing interest for sure.
So when we look at the big issues here, whereas we identify that this is a big way forward in how mental health can reach the people, the vast majority of people who need it, one is digital literacy, it's device compatibility. It is also the architecture, the intervention architecture that has to change with a person coming in to help them interpret and understand the data and help the doctor look at that, get that feedback in time to do the kind of intervention that is needed. But also regulation, right? One of the biggest things. When the government doesn't know how to regulate it, regulates it in a way that it disadvantages the whole process. So far, what has been your understanding of how this is being regulated? Like, largely unregulated, with all the software companies interested in doing these kind of mental health apps, which is what we have seen in the booming numbers, right? Is that scene going to majorly change?
It is a good question, because we can only define how will it be regulated by two things. First is when the DPDP comes into place. Are apps going to be compliant? If apps are not compliant, what is DPDP committee going to do about it? How are they going to go back and tell them that, hey, you're collecting Indian information, Indian patient data, you have to be regulated? Is there going to be a certified, like you have ISOs, you have these regulatory bodies who give you ISO certificates. Is there going to be a DPDP certificate? Those are the type of things that I would like to see in the future for Indian apps. But currently, there's HIPAA, there's GDPR that exists out in the world. Those are also not regulated. Like, it's a good to have thing. Apps can say we are HIPAA compliant, GDPR compliant, but there's no problem if they're not. You don't really have to tell anybody that you're not HIPAA compliant or GDPR compliant. So the way I see these things being regulated is the DPDP, and second thing is FDA makes it mandatory that if you want to be an intervention app, maybe not so much for phenotyping, but if you have to be a digital therapeutic app, you have to be a class 1 medical device, and for that you have to be HIPAA compliant, GDPR compliant, otherwise you should not be there on the App Store. Or if operating systems like Apple and Android be like, if you are not scientifically valid, if you don't follow data regulations, you cannot be on our operating systems. So those are the things that I would like to probably add when you talk about what are the future of regulation with such apps.
Okay, we can throw it open to audience, taking the audience question. But before that, let me ask. So I've not met you, and can I go to an app store and take a mental health app or a self-help app? And would you recommend that I do that without any of this knowledge?
Sure. If it works for you, if you're not being harmed, if you're not falling, if it's effective, it is effective for you. But if it is not, then you should probably delete it. That's what I would say.
Okay. Yeah, please.
Of a company, Monad.ai. So we were in US for past 2 years doing the same kind of research. Now we moved back to India to do the similar kind of research. I agree with the point that self-help apps are less engagement because of less human touch. We experimented, we burnt our fingers. So the one thing which we observed by researching all the mental health apps is the incentive or the instant gratification for the user engagement. Instagram, they are providing that instant gratification. Even the elderly people who are not tech savvy, they are getting addicted to those kind of reels. But even if you give them a journaling app, a meditation app, or any kind of apps, they are not giving instant gratification. So because of that, we are not able to give a tight analytics for them to pay for or maybe get value out of it. So this is the biggest issue I feel. So what suggestions based on your research you would give for entrepreneurs like us to be focused on? Having that the HIPAA, GDPR, all these things are checkbox are cleared. But what are the other areas you guys push us to look into?
Instagram is engineered that way. Most of the apps, social media apps, are engineered to be addictive. Somebody had asked me this question in one of the talks at one of the presentations was, you're suggesting digital mental apps to a vulnerable population, Can they get addicted to such apps because they're already vulnerable now? Will they get addicted? And I told them that these apps are not engineered to give you a dopamine kick. They are not engineered to make you get addicted. The problem is there's no engagement, and so that is a challenge. So when you talk about Instagrams and immediate rewards, the one thing that apps can do is probably have a little bit of gamifications, because that engages the mind a little bit rather than like boring screens. You provide the same help, you provide scientific help, but you can gamify it a little bit for them to keep using the app. We did that. It improved a little bit of our patient adherence, but we gave them the same game every day. So we had a practice effect and people got bored. But if you have different types of gamifications, scientific validity has to be the core of any app. And you asked me this question that's really nice, but you should also ask your target population. Like you should ask patients, what is the type of app that we would like to see? You will get hundreds of opinions, but if you see one opinion getting repeated with every patient, then that's probably the way forward.
Yeah. Thank you.
Hi, I had a question here. Yeah. I'm actually working on an app currently, which is more of a skill-building app for conflict management in romantic partners. Now, as an entrepreneur, my question is, when do I get the experts in to help me validate the content? Because as an approach, I'm using books that have been published. So, for example, Gottman's Fight Right is a base content that I'm using, and I'm building gamification and instruction design and emotional design based flows. But this is a prototype stage. But when do I get an expert to kind of step in, validate the approach? Should it be from the beginning? There's also constraints of funding and doing these things, right? So what are some of the considerations from that perspective? Do you have any suggestions, experience that you have?
How I'm going to look at this is, it's like you building a scale. You're building a new test. And what are the first things that we do with the test? We measure the validity and we measure the reliability. Reliability is how many times would you get the same response when tested the same scale again and again. And this is where you should get your experts in. You should do an inter-rater reliability. I am not an entrepreneur, so I would not be able to tell you very well about this. But if you have to look at it scientifically, You can look at it from an angle of conducting inter-rater reliabilities with experts once you have that skill building set ready, and that will help you to know whether it is reliable and valid through those set of experts, and then get them in to sort of discuss where were the differences in the on the points that you've disagreed on. And if you involve a statistician or you like ask ChatGPT to do the statistics for you, you will know at what point your test is ready to be significantly deployed into the market when your reliability becomes significant enough.
Can I ask?
Yeah.
Namaste. So my thoughts are like whether we will be like if we are providing any digital kind of therapeutic intervention also, whether there are any thoughts like bringing it within the definition of mental health care and treatment within the Mental Health Care Act of 2017. Yeah. If we are not bringing that within the definition of mental health care and treatment, what we may be promoting is mental health professional will not be in the picture. So it will be regulated by this mental health review board will have no role there to play to protect the interest of the patient, who is a retired district and session judge, and there is a state mental health authority will not come into picture, central mental health authority will not come into picture, then office of the commissioner of disability will not come into picture because RPWD act also will not apply to them because person with MI is person with disability per to say. So these are, what are your thoughts in that? If we are delivering something, then there is Article 14 in the Constitution which says right to equality is there. If like digital is only the way I am giving it, but it is service. So if I am giving it, there should be no discrimination between the stakeholders, those things. Just because person cannot have, example, court hearings people are doing. Now virtual hearing should be there. If virtual hearing is not there, there is an NIC studio in each district which the High Court also creates where the even prisoners are getting video conferencing that way. If you say that his right is there, then is the state has to create the apparatus to make it functional. If app base of private person is there, then within section 18 of the Mental Health Care Act, it should be defined under Mental Health Care Act. This is my thought, what you can say, because to regulate these all things are required.
I am slightly confused on the question. So the question is the question that should these committees be involved in regulations, or is the question that if there is a right to equality for everybody, why is that not there in the Mental Health Care Act? Like
How to ensure the right to equality so that even if you don't have the access, the government can ensure that there is some device, some way for you to access it. How can that be ensured, right?
Right. I'm gonna. Some of the initial thoughts that come to my mind is that digital apps are never going to replace in-person treatment, not for the near future. So the way that we can, this app is only going to be in adjunct or in addition to the treatment that they are already getting. So the right to access to apps is there. Like everybody who has a smartphone can have the apps. But whether they're the right candidate for the apps is a clinical judgment at this point. Should they be using this app? Should they not be using this app? And this is probably a little bit more different than what we were talking about regulations is. Regulations will ensure that the app is safe and effective, and the clinician will ensure whether the candidate is right for the app to be effective. So the right to equality would come with programs like digital literacy, where we try to engage everybody in digital literacy seminars or education so that everybody's at the same level of having the tools to access such apps. I'm not sure if I answered your question, but these are some of my thoughts with it.
I have a question. I was very, very excited by your digital phenotyping, and I don't know if you are aware of this organization called MindStrong in US. They were one of the earliest organization to come up and say we are going to be able to predict mental health based on smartphone usage, digital phenotyping. They even got funded $160 million, and they closed down last year. And one of the reasons why they said they were closing down is the research does not support that they will be able to predict. I was just curious to know if you have heard about it. What is your thoughts on what they said?
So Mindstrong is a very interesting case because I've spent a lot of time studying Mindstrong. Mindstrong has a lot of like soft factors that were playing. Thomas Insel was the founder of Mindstrong. He was also the head of NIMH. He got a lot of funding because he was the director of NIMH. Mindstrong, if you read the papers that they published, there are no large-scale papers that they've published. They started with phenotyping. They quickly moved on to telepsychiatry. Because when you take on $160 million, you also give control to your company to your investors. And investors decided that currently the research for phenotyping is not there, so we'll just make some money with therapeutics, come back to phenotyping. And then that model didn't work out. So the reason that they closed down is not because the field didn't have potential, but because they didn't invest their money into this field, rather into telepsychiatry. And that is one of the reasons that they probably decided to close down. They have also decided to come back alive now. So in the next 2 years, they are trying to come back to, but only telepsychiatry. They're not doing phenotyping. And that is the case with Mindstrong. So not because the field didn't have potential, but because they changed their business model. Of digital phenotyping, MindLamp. We don't have large-scale RCTs, but we do have various cohorts where we have found out that MindLamp is effective with digital phenotyping, with predicting relapse. MindLamp is an open source app. It is funded by Wellcome Trust. It is developed by Dr. John Torres. And anybody can access that. I can share the website links with anybody who would be interested. But MindLamp shows that it is effective and significant.
I have a question. I have seen in my experience with regard to the safety of women, many digital apps, but the government and the police department, they take a lot of initiative for downloading the app. Yes. But we have seen that the women, when they are unsafe and face the situations of crisis, then when I ask them, did you download it? Yes. Then show me. It's not there. Why? My phone is already loaded with many apps. This is a major problem when we are making with the apps. So as you told that digital investigator or something who can navigator is important. How we can embed into the current primary healthcare system in India. We have wellness centers, we have primary healthcare and CHCs, and then district hospital and tertiary care hospitals. So in this beautiful setup in India with regard to these different levels of healthcare system, and which is a mandate of national mental health program also. In the shortage of psychiatrists, how do we embed this app into the current government system?
Great question, ma'am. So this is something that I hear from my patients every day, that, ma'am, I have too many apps. I don't want another one. There was one patient, we finished his follow-up yesterday. The moment we finished the follow-up, he's like, can I uninstall it now, please? And I was like, uninstall it, it's fine. Like so one of the ways we can really embed these apps is by seeing value, making patients see value in these apps. And the clinician is too busy to make them see the value in these apps. So that's why I always propose the role of a digital navigator. And anybody in district mental health settings, in CHCs, anyone. We are going to start a research funded by the NIH where we are trying a digital navigator in a community health setting. Anybody can be. It's a 10-hour curriculum. There is a curriculum that exists for it. You can get certified. You need 10 hours in a day for you to get certified with that. And they teach you basic skills of how to troubleshoot, soft psychological skills. And if you go through that course, you become a digital navigator. And anybody at the primary healthcare setting can do that. And if there is a patient, let's say, one digital navigator handles 10 patients, 10 women who are interested, but they don't have the bandwidth to download these apps. That one patient will look after those 10 women, follow up with them, nudge them, with their consent, of course. Anytime they want to withdraw, no one is going to nudge them anymore. And this is the first steps to build interest with this app. Because just by telling them download it, you'll download it, and then you'll go home and delete it. Because somehow in your mind, you will know that my battery is draining, and this app that I downloaded today is draining the battery. And that is a concern. So the role of a digital navigator can be very, if there's a nurse at the primary healthcare setting, if there is a warden in the jails, if there is an NGO chief or head or a research assistant in a school or a school counselor, anybody can become a digital navigator and help with these, embedding these systems into traditional care systems.
Hi. Thank you very much. Great presentation. And I fully acknowledge the intent behind the work so that medical health facilities can be more equitable. Just a little word of caution and a quick one on that, especially coming back to the privacy and discrimination front. Like you mentioned, you would have affected communities also in the stakeholder group, especially when you're developing these products. It's also important to possibly have organizations that understand the consequences of a data privacy lapse, because HIPAA and GDPR aspects are mostly from a governance, corporate governance point of view, but DPDPA has not been implemented. It still has a lot of loopholes. And the most important thing to acknowledge is that we live in a very predatory environment when it comes to health data specifically. Behavioral data has already been taken. Recommendations of mood lighting are not the direst consequences. There are actual implementations of discrimination as to who gets what kind of health facilities. Also, when you mentioned interoperability, all the access of income backgrounds, socioeconomic backgrounds can get into predatory hands, both government as well as business. So just that. Thank you very much.
Yes, thank you. That's great feedback. Thank you so much.
Hi, Neha Tyagi. Here. I'm co-founder of Impeccable Innovations Private Limited, and we're working in mental healthcare space with our dietary intervention solutions. My question to you is that since dietary interventions also play a very huge role when it comes to mental health, what do you suggest, like how should we, promote this further? How can we gel these two things together when it comes to digital space plus dietary intervention? So I see your beautiful presentation here. So how can we gel these two things together going forward?
What type of dietary recommendations? Is it like, are you giving a diet chart? Are you tracking their diets and then giving them a diet chart?
So it's like all of this club together. So it comes to product as well as the diet chart, as well as the, we follow and track the overall, how they're taking it, how they're taking the meals, what time of the day and all those things, yeah.
So, I'm sorry, I didn't get your question. So the question is, how can we integrate diet and mental health through these apps?
So, yeah, exactly. That's what I'm asking.
It is a protocol that we'll probably have to research as to what has been done and what were the challenges when it was done. Because I absolutely acknowledge that there is a biopsychosocial model of mental health, and you need to be. It's not that if you don't eat well, you will not feel anything. You will. Your mood will get affected by your diet, and if there is a way to integrate them, it should be well evidenced and it should be researched well. And that is something that only past research can tell you of how it has been integrated into the past. And my advice would only be to look at the challenges that they have faced and probably try to reverse engineer from the challenges that have happened.
Yeah, thank you.
Yeah, hi. This is Chandra here. I represent MPAR, Aditya Birla Education Trust. I have this question. You mentioned that the rural community are using the app much more frequently than the urban. I personally feel it's also because they tend to follow a structure. You give them an instruction, they follow it without questioning, and they trust their clinician or a therapist. And when it comes to urban population, they know a little too much about therapy or about mental health already. So I feel it's also a drawback for mental health because they self-analyze and they self-diagnose themselves and they know what to do. See, I'm a clinical psychologist by profession, and I've come across many Gen Zs saying that, I don't trust psychiatrists or psychologists anymore. I don't need your help. Like, if I need my help, your help, I'll get back. And they frequently change their therapists as well. So in this case, how digital the media is going to help the Gen Z to follow, and it's a brilliant thing. I really loved the way you mentioned. I think it will really help the therapist also to get their behavior in a week's time or a month's time in a fraction of a minute. You need not spend so much time taking that history, So, but if we can channelize this better, I think it's going to be wonderful. Thank you.
Agreed. So first I would like to clarify, I'm not saying that rural people are using apps better. I'm saying they have access to phone and internet. There is a penetration of smartphones and internets which is now increasing in the rural populations of India as compared to the urban populations. I don't have numbers on whether rural people use apps more or like as compared to the urban population. That I'm not sure. But for my study, I have more people who are from those backgrounds, and they are very happy to use the app, other than the one who wanted to uninstall yesterday. But if your question is why are the urban population not interested in in-person therapy, and how can digital mental health tools help them, is that your question? My answer would be, so there's something that I was discussing with Natasha. I don't know if she's here right now, but she was telling me, what do we do when youth self-select themselves into cohorts of apps that they can relate to? For example, somebody sees an advertisement for depression and think, okay, do I have depression? My friends were telling me I'm depressed, so maybe I self-select myself into this app, and they use it. Is that a problem? It's only a problem if it's harmful. It's only a problem if it is not being helpful, or if it is only a problem when they can only think of this app and nothing else, and it leads to abnormal behavior. And those things don't really happen. That's not something that we have seen in research. So the way a digital tool can really help youths or urban populations would have to come from either their interest, that would be self-help apps, but we know what happens with self-care apps, or it has to come from their institutions where they say, okay, there's a school counselor, college counselor, we are recommending these apps, and if you want to discuss these insights with us, come, help, we'll help you discuss. Or the peer support apps, they don't want to come for in-person therapy. They just want to know how they're feeling. They want to get some maintenance therapy. Then they would be going for those guided approach of cares, which is they go on a peer support app and they use it to get some basic level of therapy that they need. And then that is escalated to more hybrid approaches with clinical psychologists in person, and then there's somebody nudging them to use those apps. So urban populations are anywhere across India, I feel care model, what approach to use with anybody is going to be very individual dependent, what is suiting their needs. And hence I like the hybrid approach where you can sort of fluctuate and increase or decrease the level of support that you need. So that would be what I would say.
Hi, I'm Malika, and I practice psychoanalytically. How would you ensure depth? I have patients and I ask them to journal. I ask them to write down their dreams, which often get lost, and it helps a lot. It's not an app, but yes, I'm relying on the digital support. How would you, the risk of standardization because of these apps? Well, I'm very happy to hear your presentation, and it's very encouraging to see how mental health experts, we could probably smoothen certain processes, but this problem of subjectivity, a person's dream states, their personal stories, would they get missed? How would you think around that? Thank you.
So that is a case of an active data input. If they have dreams, if they have subjective feelings, if you're asking them to journal on an app, it would only get missed if they don't journal. Is somebody an app-based journaler, if that's a word, I don't know. Do they like to journal on an app? Do they like to journal in a diary? Do they like to journal or sketch? It has to be very individual dependent. I know a lot of apps that ask that. There are integrated apps into Apple phones now where they ask you to remind you to send your journal. But do people really like to use it? It'll probably be very treatment dependent upon what kind of individuals, what type of methods that they like to support. The only reason I could think of why people would want to journal in an app would be there are these journaling apps sometimes you don't have the words of how you're feeling, right? Like you then can select feeling anxious, feeling okay, had a good dream, had a bad dream. You get these objective drop-down menus, and that helps you to journal down your feelings. And that is one of the ways that psychoanalytical approaches could use these apps, is to help people, give them the words that they don't really sort of can find when they want to journal those things.
I think with that, our time's up, so we'll round up the session. Thank you so much, Soumya, for being here and helping us with this.
Thanks so much, Soumya and Leena, for that.